On the behalf of our presentation number 79, I thank All India Ophthalmic Society for giving us this opportunity to have this IC on this AIOC virtual platform. So topic for today's discussion will be dodging the bullet, achieving successful cataract surgery when the ocular comorbidity challenges the outcome. Today, we have with us distinguished speakers from all across India who will be presenting their views on different challenging conditions. Dear friends, normal cataract surgery is a piece of cake. Anyone with the knowledge of doing the surgery can achieve successful results. But surgical outcome becomes a challenge when patient with cataract presents with a coexisting ocular morbidity. So we all will be discussing about different challenges, starting from corneal diseases and going up to vitreoretinal pathologies. And we will discuss in terms how to manage these complicated cases to get the best possible surgical outcome and patient comfort. In the beginning, I will start with Dr. Veer Vikram Schiller. Dr. Veer Vikram Schiller is MS from PGIMS Rohtak. He is a fellow in glaucoma from Arvind Eye Institute, Madurai. His special interest in cataract surgeries and refractive surgeries with the interest in glaucoma. He has numerous international and national surgical presentations. He is speaker at national and state level conferences. He has multiple publications in various journals and owns a practice in Delhi and Gurgaon. He is a noble gentleman, good friend of mine. He will be talking on the challenges of axial length on cataract surgery. Over to you, Dr. Vikram.
Yeah. Thank you, Dr. Saurabh. Thank you for such kind words. Cataract surgery in abnormal axial length. Good morning, everyone. First of all, I'd like to thank All India Ophthalmic Society, Chairman Scientific Committee, Dr. Partha Biswas, and Dr. Saurabh Mittal for giving me this opportunity. Abnormal axial lens, the two wide spectra are long and short, that is myopia and hypermetropia. There's incidence of around 25% of myopia and most in the Asiatic race. High myopia is labeled as greater than -6 diopter, and its incidence is also around 2% of the population. That's quite a huge number. And pathological myopia is labeled as myopia greater than -8 diopters. We face surgical challenges at all the various stages of surgery. Apart from the routine preoperative evaluation for a cataract case, special emphasis should be paid on retina. Periphery of the retina should always be screened for breaks, and macula should always be checked gently for RPE changes, for any atrophy or neovascularization of the choroid. But sometimes periphery checking is not really possible due to lenticular changes. Biometry, optical biometry really useful, especially when you have posterior staphylomas. Otherwise, immersion should always be done. And SRKT formula is a chosen one for long eyes. Long eyes have a thin sclera. So there's always a risk of perforation when we give either a retrobulbar or a peribulbar block. So topical anesthesia is considered the safest in these cases. And as there's a lot of iris movement, it's always advisable to use intracameral lignocaine. The incision of choice is again a clear corneal incision. Always make a slightly shorter and a little posterior tunnel. Long tunnel makes the instrumentation go vertical down and manipulation becomes difficult. And if by chance you have to make a sclerocorneal tunnel, then it should be a shallow one. This is a video which shows the tunnel being made. This is a normal tunnel. What we just see the stroke length of this tunnel. This is nearly a square type of a tunnel. And when we make it for a myope, the tunnel is more of a rectangle one with a long length that the length see that is on a limbal side. Rexes should always be attempted somewhere around 5 millimeters because they will appear small due to larger size of the cornea. Larger rexes size can lead to increased chances of PCO. Eyes which are myopic always have deep ACs, and then so there is more anterior posterior movement of the nucleus and the capsule due to lack of zonular strength and formed vitreous. This is a video showing the rexes in case of myopic eyes. You can see sorry. As we complete the rexes, this is just to show how the rexes will look at the end when the surgery is completed. We aim for a slightly shorter rexes in these cases. This is how the rexes looks like. It should be a slightly smaller one. Sometimes due to zonal laxity, it is not practical for us to make a nick in the capsule. So either you can do it with a cystotome, or what we actually do is we take a MVR, make a small nick in the anterior capsule, lift it up a little, and then we proceed with the rexes. Reverse pupillary block or the lens iris diaphragm retropulsion syndrome is especially common in high myopes and an area of concern. What actually happens in this video, you will see while we talk. We have done a rexus for this patient, and as we go to do phacoemulsification, go on to the paddle irrigation, you see that it is all ballooned out, it is dilated a lot, and this is 360-degree occlusion of the iris with the anterior capsule. This leads to a lot of pain and deep myopia. The best way to handle it is to take your chopper, nudge it slightly beneath the iris and lift it. This will equilibrate the pressure between the anterior and the posterior chamber, and your job becomes easy. Another way is you can always, while operating, drag the iris a little with the belly of your chopper. This really literally tenses your iris a little. You can see from here where the chopper is coming out, and this just pulls up the iris a little, and then it's always an equilibrium between the anterior posterior chamber, and you can get rid of this retropulsion syndrome. And another way we can do, if you are so worried, you can always put one single iris hook that will take care of it all through the surgery. You should always avoid AC collapse in these cases, because that puts a traction on the vitreous base and increases chances of RD. So for that, to always fill your AC with the visco OVDs, and IOL placement should always be done under copious visco or with a side port irrigation on. This is a video which I've been trying to show how you come out of it after doing the final irrigation aspiration. As we take out the IA probe, it should be gently. And another good aspect of short tunnel, which we can do to advantages, it plugs the wound between iris prolapse, and thus AC remains out. You should always remove OVDs, especially from behind the Iols. Short tunnels are not easy to close. You have to always hydrate the tunnel, or if that's not setting in, then you suture the wound. This is a video which will show how to clean the visco from behind the IOL. And this video will show how to seal the tunnel. You'll see I'm trying to do multiple attempts to seal this tunnel. It is not sealing so easily. Multiple pushing in of the iris, then ultimately we'll be able to settle it. And still it doesn't seal with hydration, always safer to put a suture out there. Post-operatively, always look at the earliest possibility for the periphery of the retina to see for any breaks. And if by chance PCO develops, you should always do a YAG with a very low energy. It is important to understand the anatomical difference in small eyes for surgical planning. 83% of the short eyes are hypermetropic, and most of them have uneven full surgeries. But it is really vital to distinguish nanophthalmic from the hypermetropic eyes, because they are fraught with complications. Both of them have short axial length nanophthalm and axial hypermetropia, but the nanophthalmic eyes have a shallower AC, while hypermetropic eyes have nearly a normal AC. Various challenges in the pre-op. You should be always evaluating these patients for glaucoma, do a gonio, a UBM to look for peripheral choroid effusions. A B scan should always be done, and optic nerve head evaluation, look at the iris for colobomas, and if it is his amblyopic, explain the prognosis to the patient. Look for other ocular cystic pathologies. Optical biometer or immersion, if done, Hoffer Q is the formula of choice and should be done with a reduced gain. You should always manage the IOP prehand, either with the help of medicines or mechanical compression or intravenous mannitol. Topical anesthesia is always preferred. Incision should be clear corneal, temporal, a slightly longer and more anterior tunnel This has to prevent iris prolapse. And incision, prefer a 2.2 millimeter incision because the cornea is already small, and 2.8 will give sufficient or a little more astigmatism. This is a video which will show how we make tunnel in the hypermetropic eye. You see, this is, we start with making the tunnel, the 3-plane. This is the normal stroke, and with a little slightly more stroke to make it slightly more longer tunnel. During surgery, these eyes have more chances of miosis to keep pharmacological and mechanical pupil expanders ready. Rexes is planned according to the size of the IOL. Shallow AC is quite common, and it is important to manage it to prevent difficulty in rexes, to prevent iris prolapse, to avoid endothelial cell loss, and prevent PCR. For that, you can raise the bottle height, or you can use a lot of viscoelastic, or to start with the surgery, remove a chunk of the epinucleus from the center, so that gives you a little more space. Use a Kelman needle and keep the instruments and the nucleus piece away from the endothelium to prevent its damage. If the AC is shallow at the beginning of the surgery, do a limited pars-plana vitrectomy to make a sclerocorneal tunnel. And if the pressure develops during surgery, that is after the initially a normal AC, it indicates there's a choroidal effusion. So do a sclerotomy by maintaining AC with BSS. This is a video which will show how to make that initial small gutter in the epinucleus so that you have got more working area. This is a video which will show how to put an IOL anyway. Then for piggyback IOLs, you should always put the piggyback anterior and preferably of a silicone oil. It is placed in the sulcus. It should be of a lower power, and the haptic should be perpendicular to that of the lens in the back. The wound should always be tightly sealed either with hydration or with suture. And in the post-op, always keep a tap on the intraocular pressure and spatial evaluation for interlenticular opacification in case of piggyback IOLs. Thank you. Thank you very much.
Thank you, Dr. Vikram, for such a wonderful presentation. Now, next we will be going to Dr. Love Kochgave. Dr. Love is a wonderful surgeon. He belongs to Calcutta. He did his post-graduation did his graduation from Bangalore Medical College, and he did his fellowship from Shankar Nethralaya. He is at present heading Netralayam and BBI Foundation, Calcutta. He will be presenting on cataract surgery in cases of ocular trauma. Over to you, Dr. Love.
Thank you, Saurabh, and it's a great pleasure to be speaking on this forum, and hope my slides are visible.
Yes.
So I would be speaking on traumatic cataract, and as you know, just an introduction slide before I go to the videos. The various presentations may be in the form of a blunt or a traumatic penetrating trauma, and in case of penetrating trauma, the timing of surgery is very important, and that is where we come into play. Most of the patients, what we get is from peripheral area and where the general anesthesia facility is not available. And so that initial 6 hours gets lost there, but we are able to salvage in whatever way we can. So let us go to the various presentations and videos of traumatic cataract surgery. Now here in the first case, what you see is a pre-existing anterior capsular tear through a penetrating trauma, but the patient presented to us late and the corneal wound appeared to be self-sealed. So we decided to do the cataract surgery. Again, biometry is a problem in these cases. Many times we have to rely on K reading of the other eye, axial length of the injured eye. And what you see here is that after the initial cortical aspiration, the anterior capsule is being trimmed using a high-speed cutter. And we get a very good, smooth anterior capsular margin with this, the 23 gauge high-speed cutters. Then the IOL is implanted, and we try to implant the IOL in the bag with whatever remnant of anterior capsular opening we have. so that the lens is stable for long term, and most of these are children, so it is important for that. And during the procedure, what we noticed that the main wound had opened up, so just one suture there did the trick for that. And as it is a child, a small child, then we have to suture the main port also. After this is done, then posterior capsulorhexis and anterior vitrectomy is done. And if done neatly, these children do have good significant vision, so it is not all loss for them. And AC is stabilized with air bubble in the end. So this is one scenario. Second scenario, this is one of the complication related to COVID. The child had a trauma and then could not present to us early enough. And by the time the child presented, the anterior capsule had got all fibrosed. And fibrosed anterior capsule in a traumatic case is an indication that it is an old case. So problem here is in the rhexis. We started with the non-fibrosed area, but at one point it will get stuck in the fibrosed area. So no point pulling it beyond this. And then the cutter is used to cut the fibrosed portion of the anterior capsule. And again, that while cutting such thick membranes, it is the cut rate can be little bit lower and higher vacuum. Then the, membrane cutting is much easier using the vitrector. Very high speed and cutting is not good for membrane. It takes more of time. High speed is more useful for vitrectomy. So as you see, we trimmed the anterior capsular opening, and we got a good, nice sized, almost round anterior capsular opening. We cannot call it exactly as capsulorhexis, but it is a good capsulotomy. And after the cortical aspiration, the bag is well formed and the lens is implanted in the bag. So if the retina, if the impact of the blunt injury is not there on the retina, this child would get very good vision. And as usual, the posterior capsulorhexis, and most of the time, last 7-8 years, I've been doing only with cutter. I've given up a manual posterior capsulorhexis. Now, another scenario what we have, what we may get in traumatic cataract is the foreign body. And the case is somewhat similar to the first case, but only to demonstrate what we can get. What we see here is a foreign body, and the foreign body is removed from the main port. And then we proceed as usual. The anterior capsulorhexis is completed through the portion which is more of capsule is there, and other side is not required because there is a large gap there. And then the IOL is implanted in the bag. And this is the pre-op and post-op picture of the same case. Another scenario, what we get in traumatic cataracts is the dense posterior synechia along with traumatic cataract. And what you see here, first the posterior synechia is released, and then the pupil is little bit, it is stretched so that we have a good visualization. Iris hooks are used. And here again, you have a fibrosed anterior capsule. And one good thing about traumatic cataracts, in cataracts with experience, what happens, we operate at subcortical level, we don't have to think much. But in traumatic cataracts, for each case, we have to do a planning for the best outcome in that child. And here again, after the cortical aspiration, what you see is a very thick fibrosed anterior capsule. So this has to be trimmed because in later on, this will get fibrosed further and start coming to the visual axis. So bag is well formed. The anterior capsular opening is being trimmed so that we get a respectable size for IOL implantation. And most of these cases, if done properly, the anterior rhexis margin doesn't extend. And as you see in this case, even the posterior capsule is fibrosed. So with the cutter, a good sized opening is being made. And at the end of it, the pre-op and post-op pictures shows that there is how the child would have benefited after the surgery. This is how it looks post-op. Another important thing, this is a blunt trauma, and if you see the posterior capsule, if you visualize that, even before the surgery, you can make out that the posterior capsule has given way because there is a thick wedge-shaped opacity seen through the total cataract in the posterior capsule. So very careful, no hydrodissection. The cortex is aspirated first, and then this was a wrong thing what I did during surgery. I decompressed the anterior segment, and that led to vitreous prolapse in the AAC. Better would have been to push viscoelastic and then remove the surgical instruments. And then once vitreous is there, it has to be tackled with the cutter. And once it is clear, then the IOL is dialed and is well centered. In this case, this is the first case of all the demonstrations I have made. The IOL was placed in the sulcus. And probably the final scenario in traumatic cataract is the subluxated lens. And what you see here is a gross subluxation almost 5 to 6 clock hours. But the good thing is that these are non-progressive. So once we do the surgery, then probably the stability of the bag will be maintained. It will not progress further. So after initial capsular access, and what you see, the vitreous is prolapsing in the anterior chamber. So that time you have to remove your irrigation aspiration and go in with a cutter. The dictum is, as soon as you see vitreous in the anterior chamber, then there is no role for irrigation aspiration. It has to be dealt with a cutter to prevent vitreomacular traction or vitreous traction, sorry. And after that, once the bag is clean with the cortical matter, the CTR is implanted, and still you don't have a very well-centered bag, but and in these cases, it is better to implant a biconvex lens than aspheric lenses. And the lens has been implanted, and another 30 seconds remaining. And the vitreous is cleared from the zonular weakness area. And this is what you get at the end. Fairly well-centered IOL and should have a good vision. Thank you so much. And thank you, Saurabh, for this opportunity. I will have to leave.
Thanks a lot. Dr. Love is a pediatric ophthalmologist at Calcutta, and he has received his numerous awards at international presentations also. Our next speaker will be Dr. Abhilasha, and I'll ask Dr. Abhilasha to share her screen. Dr. Abhilasha Bharani, she did her DNB from Arvind Eye Hospital, Tirunelveli, and Tamil Nadu. She did her fellowship in uveitis and ocular inflammation from Arvind Eye Hospital, Madurai. She did her fellowship in ocular inflammatory disease from Royal Victoria Eye and Ear Hospital, Dublin, Ireland. She has received a Carl Herbert Award at the Uveitis Society of India in 2012. She got an Award of Distinction and Award of Merit at International Ophthalmology Congress, Innovations and Challenges in Glaucoma and Uveitis in Singapore 2014. She had a Best Poster Podium presentation for uvea at All India Ophthalmic Society in 2019. She had numerous publications and presentations. She's also written a chapter on ocular tuberculosis in book OCT and OCTA in retinal disorders. Over to you, Abhilasha, for your presentation on cataract surgery in chronic uveitis.
Thank you, Dr. Saurabh, for the kind introduction. I hope my slides are visible.
Yes, ma'am.
Okay, so I thank Dr. Saurabh and AIOS for giving me this opportunity to present my talk on cataract surgery in chronic uveitis. So cataract is the most common surgical indication in uveitis, accounts for 40% loss of vision, comprises 1.2% of all cataract surgeries, but post-op BCVA is 1 to 2 lines worse than in non-uveitic eyes. So in this talk, I'll be talking about the pre-operative assessment and preparation, intra-op challenges, and post-op complications and their management. So many a time, this is the picture that we see, and for assessment of the posterior segment, we only get to see the B scan. But apart from vitritis, the choroidal thickness should also be paid attention to because it is a marker of inflammatory activity. Wherever possible, the visual potential should be assessed by looking at the optic nerve function, as well as looking for glaucoma, which can be easily missed when you are busy managing uveitis. The macula should be assessed for the presence of a scar, CME, ERM, or even a full thickness hole, and the patient should be treated or appropriately counseled. The most dreaded complication is hypotony, which can also result in phthisis bulbi. The risk factors are intraocular pressure less than 6 millimeters mercury when the eye is quiescent, seclusion pupillae with a normal IOP, and a poorly controlled inflammation. Ideally, this surgery should be taken up when the eye has been quiescent for 3 months, but generally early cataract is also preferred to assess the posterior segment pathology, and also because advanced cataracts pose greater surgical challenges. The patient needs to be appropriately counseled about the visual prognosis beforehand, and that the surgery takes longer than usual, and the possibility of a delayed visual recovery. It should be insisted upon the patient to comply with the medication even when the surgery has been done, and come for frequent follow-ups. Many of these patients are young and they should be told that they need reading glasses post-surgery. Pre-operative preparation, steroid prophylaxis is required only in those cases where there is risk of macular edema or a recurrence, and oral or local steroids may be preferred. Where there is chance of recurrence of uveitis, like in toxoplasmosis or herpetic uveitis, prophylactic antibiotics should be started 1 week before surgery and to be continued 1 month later. The choice of surgery is, of course, phacoemulsification. Where there is coexisting cataract and glaucoma, cataract should be done first, because anterior segment inflammation because of cataract can result in failure of the glaucoma surgery. Where there is coexistent cataract with retinal problems, a combined surgery can be planned. Anesthesia is surgeon's preference, but I prefer subtenal anesthesia because it is safer and affords more comfort to the patient, and it can be easily given with this curved 23 gauge cannula. Coming to the intra-op challenges, now I'll be presenting the challenge of a small pupil that we face, and this is 2 eyes of the same patient. So this is the first video. I'm operating on the left eye. In this eye, I had planned for iris hooks. And first, before putting the hooks, the posterior synechiae have to be released. When we are making incision for the iris hooks, the MVR blade should be inserted such that the tip points towards the pupillary margin. This makes the engagement of the iris easy. A long tunnel is not required. The iris hooks are tucked in and the iris is engaged. Here, I'd also like to stress upon the fact that the etiological diagnosis of uveitis should be made. Every attempt should be made to look for an etiological diagnosis and start the patient on appropriate treatment before taking them up for surgery. So as you can see, I'm placing the iris hooks in a diamond configuration. So this is a diamond configuration where the main wound will lie over the iris hook. Now the iris hooks are being tightened sequentially. It's better not to tighten them at once because that can lead to large sphincter tears. So we are tightening, I'm tightening this iris hooks in sequence. Now making the main incision above the plane of the iris hook. Yes. So this way, when we enter with the phaco probe or when we are inserting the IOL, we don't tend to injure the iris. So if you make a square configuration with the iris hook, there is tenting of the iris. And when we are entering with the phaco probe or any instrument, we are likely to damage the iris. Now removing the iris hook is very straightforward. We loosen the clamp and just rotate the hook and remove it. It's also important to clean the viscoelastic thoroughly at the end of surgery. Any residual viscoelastic is likely to contribute to the post-op inflammation. So here I'm cleaning the viscoelastic from behind the IOL thoroughly. All the side ports are closed and subconjunctival dexamethasone is given. That's the end of the surgery. Coming to the second eye of the same patient. In this eye, I am proceeding with the subtenon block. I'll enter the subtenon space, the closed scissor. Subtenon block is given with the curved 23 gauge cannula. In this case, I have planned a B-hex ring. So posterior synechiae are being released from both sides. Now, B-hex, before implanting the B-hex ring, we have to do a stretch pupilloplasty. Viscoelastic has to be injected even under the iris to provide room for the B-hex ring. Now, this is the ring. It is a non-elastic ring. It has got 6 flanges with dots and without dots and flexible notches. So you engage the B-hex ring there. And a 23 gauge forceps has to be used for doing this. Removing is also straightforward. It comes out easily. B-hex ring provides more room for surgery compared to iris hooks. And again, cleaning the viscoelastic from behind the IOL. And that's the end of the surgery. Coming to the comparison between iris hooks and B-hex ring. So these are 2 eyes of the same patient. So pupil size that is almost the same between the two, but the B-hex ring provides a better circumference, so rhexis becomes easier. The learning curve is slightly steeper in B-hex ring, but if you use the recommended 23 gauge forceps, it's easy. Surgical maneuvers are also easy in my experience with B-hex ring, because the iris is not tented and there is more space for you to work. Surgical time is also less for B-hex ring. Post-op distortion of pupil is also lesser with B-hex ring. However, the post-op astigmatism was equal in these 2 cases because of extra side ports for the iris hooks. It did not affect the post-op astigmatism. Post-op complications, aggressive post-op steroid should be given. I prefer a difluprednate with NSAIDs to prevent posterior synechiae and pupillary membranes. The pupil has to be kept mobile by using home atropine BD. So the principle is to over-treat and relax and not under-treat and then try to catch up with the inflammation. Posterior capsular opacification and phimosis is common. You can get this kind of cocooning of the IOL. To prevent this, a circular large rhexis should be done. Acrylic IOL with square edge design is preferred. Meticulous removal of viscoelastic like I showed in the video, and there should be good control of post-op inflammation. Thank you.
Thank you, Dr. Abhilasha, for such a wonderful presentation. Before we proceed to the next presentation by Dr. Amit Porwal. Mr. Raj?
Yes, doctor, I'm here. Yes, doctor, I'm here.
Yeah, we are supposed to take a photograph before
Yes, sir.
Yeah, please.
Yeah, just give me a minute.
Chekitan, if you can on your video, on your camera. Anirudh Singh, Sanita Satyan. All of you who are present as a panelist, please on the video so that a group photograph can be taken.
Dr. Love is not there.
No, Sanita is there in the next course, but they can show up their face. Okay, done?
Yes, sir. Shall I proceed?
Yeah.
Thank you. Thank you, Raj.
Thank you.
Our next speaker is Dr. Amit
Sir,
Porwal.
just a second. Yes, sir, please.
Thank you. So our next speaker is Dr. Amit Porwal. Amit Porwal is a postgraduate from Jawaharlal Nehru Medical College, Belagavi. Did long-term fellowship from Arvind Eye Hospital, Coimbatore. He is a teacher and a trainer in glaucoma and cataract surgery since last 19 years. He has been awarded with NIO Gold Medal, IIRSI Gold Medal, iBeach Film Festival Gold Medal, and South India's Got Talent Award. He is a section editor for Ophthalmic Education section in IGO, Editorial Board, DOS Times, and UP Journal of Ophthalmology. He has delivered more than 500 as invited guest faculty lectures, and he has publications in index and non-index journals. He holds the position of All India Society, ARC Central Zone and Central Zone Executive Member, and Glaucoma Society of India. Currently, he is also holding following positions: Member Scientific Committee of All India Ophthalmic Society, Chairman Scientific Committee, International Society of Manual Small Incision Society of MP Chapter. He is a Senior Consultant and Head of Glaucoma Services, Jyotiram Netralaya, Indore. Over to you, Dr. Amit Porwal, and he will be presenting on cataract surgery in glaucoma conditions.
So my slides are visible and I'm audible, I hope so.
Yes, sir.
Yeah, so thank you, Saurabh, for the good, for such a nice introduction. It was the ex-Central Zone Executive for Glaucoma Society of India and ex-Central Zone member of Academic and Research Committee of AIOS. Presently, these are my affiliations. So I'm going to talk on cataract and glaucoma, way to go. So no financial disclosures. We all know that cataract and glaucoma is the leading cause of blindness worldwide. It is the most common ocular condition associated with the aging process. And its prevalence is increasing due to increase in the lifespan, and also there is an increased risk of sclerotic cataract with elevated IOP and with glaucoma medications. So the question is, how do we manage this coexisting condition to promote the best visual outcome? So the initial decision making is crucial in determining the type of intervention in this coexisting disease. So approach to a patient with this combined disease depends. There are three surgical approaches. You have cataract extraction alone, you have sequential surgery when you do trap first, followed by the cataract surgery, then you do a combined cataract and glaucoma surgery. So what are the indications for cataract extraction alone? You have a visually disabling cataract in which you have the patient is having an IOP under good control, you have a mild glaucomatous damage, you have minimal visual field loss, you are on one or two well-tolerated anti-glaucoma, topical anti-glaucoma medication, and also the patient is compliant with the anti-glaucoma medications. So what are the advantages? We all know there is a long-term IOP reduction after 5 years. There's no need of less post-operative medications are needed. And the disadvantage is there is an early post-operative IOP rise, especially within the first 2 hours, which lasts for about 24 hours. So close monitoring of this IOP is very crucial. Coming to the sequential surgery, that is a two-stage approach, wherein you do a trap first, followed by cataract surgery later. What are the indications? Basically, the glaucoma dominates the clinical picture in these patients. There is a significant optic damage, there is advanced visual loss, and there is uncontrolled glaucoma despite maximum targeted medical therapy. So this cataract surgery can be done 4 to 6 months after the trap is done once the lab is well established. So this is called as a two-stage procedure. Disadvantage, we all know it needs two separate surgical procedures. The cost also is involved, and the filtering surgery might hasten the cataract development, and the cataract surgery might cause the blood to fail later on. So coming to the triple procedure, the indication is cataract in glaucoma patients in which there is failure to achieve target pressure by medications. There are issues related to compliance, adherence, and drug-induced side effects. There's a borderline control IOP, disease progression or advancement despite maximum medical therapy, and there is an uncontrolled glaucoma, but an urgent need to restore vision, and when two operations are not feasible, especially in our diabetic patients. So advantage, we all know that it eliminates the need for two separate surgery, cost is reduced, there's significant improvement in visual acuity and IOP. So both these issues are addressed at the same time. Coming to the surgical considerations, you have the pre-operative considerations in which you have to do a proper examination, try to find out what is the cause of vision loss, whether the major cause is due to cataract or due to glaucoma, do a proper slit lamp evaluation, look for pseudo exfoliation, shallow anterior-chamber myotic pupil, because most of our glaucoma patients have these coexisting abnormalities. Look for the fundus examination to rule out whether the vision loss is more due to glaucoma optic atrophy or due to any other macular pathology. Operative considerations, the previous speaker has properly taught us how we are going to deal with the small pupil strategies, because we as a glaucoma surgeon come across a lot of patients with small pupil, and these patients have irreversible miosis. So if you're doing a phaco, you can use pupil expansion devices like rings, hooks, and expanders. Like my choice has been hooks and expanders. I've stopped using hooks, rings, I think from last almost 6 years. Even if you are doing incisions, do a stretch pupiloplasty, microsphincterotomy, or a sixth-pyelectomy. Viscoelastics of choice is sodium hyaluronate. It maintains a flat AC and also deburrs it, especially helpful in chronic angle glaucomas. But it should be thoroughly washed at the end to avoid post-operative IOP spikes. We all know that HPLC causes less post-operative IOP elevation when we are comparing to sodium hydroxide. Operative considerations, the Rex's size, Iols is all dictum, and standard dictum, what we have been taught in cataract surgery. But what I would put a word of caution is the ACIOLs has to be avoided when you are doing cataract surgery in glaucoma patients, because you don't want the IOP to be right. Then coming to the sequential surgery, wherein the cataract incision should be positioned to maximize the pleb survival. In this sequential surgery, you are doing cataract extraction after filtering surgery. So the incision site depends on the initial filtering pleb. So the temporal location is preferred. A phaco with foldable iode to a clear corneal incision is a surgery of choice. And most of the time we come across this posterior synechial because of the previous surgery. So synechial lysis is must, and we have to be mentally prepared to what we are going to do. So in this case, I'm going to show a cataract extraction after filtering surgery. You can see there's a superior nice pleb, and then there are posterior synechials also, and it's an intumescent cataract. So I'm showing a surgery. So what precautions you have to take? This cataract incision should be positioned to maximize the pleb survival. The incision site depends on the location of the filtering pleb. So here there is a superior pleb. So I'm doing a temporal location. You should always do a slow motion phaco, but you should not be so slow that you prolong your surgical time, because if you prolong the surgical time, there's a lot of turbulence, and then your chances of blood failure will increase. So phaco with foldable is surgery of choice, and synechial has to be done. So just a quick review. This video, how we are going to handle this. So do any preferred technique of a phacoemulsification. Now coming to the triple procedure, you have the single site and the twin site. Single site, you can do an SICs or a phaco with the trap to the same site, that is superior. It involves less surgical time. Two site or twin site is you do a superior trap and do a temporal phaco. Temporal SICs is not advised because it's a large conjunctival dissection. So a superior trap and a temporal phaco is what is advised in the twin site. The only disadvantage, there is no surgical time. So there are two parallel videos I'm showing you in this. You have the upper one is the single site, which is the SICS plus IOL, and the bottom one is the twin site, which is the phaco plus IOL. So the first thing what you have to learn is to take a proper traction suture. You can take a superior rectus traction suture or a corneal traction suture. Why this traction suture is important is because it gives you better exposure. And once you are going to mark the conjunctival flap, always mark the conjunctival flap with the help of a caliper. Cut the conjunctival flap in one go. Do the meticulous posterior as much as posterior subconjunctival dissection. Identify the bleeders and only cauterize the bleeders. Don't over cauterize it. If you over cauterize it, you will have shrinkage of the scleral flap. Now, if you want to use antimetabolite, you can use this after making the scleral flap, just marking the scleral incisions. You can put these wax sponges, or before that you can do. But the only dictum when you're using mitomycin is you have to remember that you should use wax sponge, never use cotton pellets, because you don't want any cotton fiber to be left back into the subconjunctival space, and to avoid the complication of this antimetabolite. Again, mark the scleral flap. Then with the help of a 1-tooth forceps, raise the apex of the scleral flap. Just the cutting edge of the 15 number blade is just touched, and you get a nice nick. So keep on stretching the scleral flap superiorly and just touch the cutting edge of the 15 number blade. And you can see I'm doing the same maneuver. I'm just lifting up the scleral flap tightly and just touching the cutting edge of the 15 number blade, and you get a nice uniform scleral flap. So once this is done, when you are doing an SICS, you then take a crescent and proceed normally as you do your manual small incision cataract surgery. And when you are doing a twin side surgery, now you have to shift from superior side, you have to shift your chair to the temporal side. Now you have to sit on the temporal side and then proceed with your phaco surgery. So the steps of the cataract surgeries remain the same now. From this step onwards, you don't have to alter your cataract steps. Only thing is you be more vigilant and more mentally prepared as to what all complications can be seen. So you can see when I'm doing a phaco trap, as I told you, small pupil are the cases which we as a glaucoma surgeon experience a lot. So this is a case of Malugin ring. I'm injecting through the same incision which was created for the phaco. Now you have to remember why I told you initially also that I have given up using iris sources. If the pupil is rigid also, you can do a stretch pupilloplasty and then inject this Malugin ring, BX, or the OSS iris expander. They are not expensive. I usually clean and ETO it. So at least 4 to 5 times we can reuse it. So the cost is very cost effective. And if you look at the BX, it is very cheap. So I think this is better because 2 incisions for the biomanual, then 1 incision for the main tunnel, and then 4 or 5 for the iris hooks. It will be like multiple dots on the corneal limbus. So I advocate to use expansion devices and not the iris hooks. So proceed with your phaco surgery of choice. I usually do a stop and chop technique, and depending on the hardness of the surface of the cataract, I might convert to a direct chop or a flip and chip technique. So whatever technique you're comfortable, do that. Now you can see that I have finished my SICS and I'm making an internal ostium in the upper video with the help of 11 number blade. So 2 by 1 millimeter is the size of the internal ostium. Now this iris is popping out. All this iris popping out can be avoided. Is basically you have to maintain the anterior chamber adequately. Never overfill the anterior chamber with the visco. If you do that, what happens is the moment you are trying to cut the trabecular meshwork, there will be iris prolapse. So once the trabecular meshwork is cut, do a nice broad-based peripheral iridectomy, and this is a technique of suturing the scleral flap. When I'm doing an SSDS trap, initially I used to put one intermittent and two releasable suture, but now I changed to only one releasable suture, whether it is an SICS trap or a FICO trap. So the technique of releasable suture, you pass 10-0 parallel to the limbus into the clear cornea, then from perpendicular limbus from the clear cornea into the scleral flap, and then from the scleral flap into the intact sclera. So this is the way you're going to take the suture. Then take 4 throws, and once you've taken 4 throws, there's a slip knot. Go pass these throws over this loop. You can see the way I'm passing it and tighten it. So this is the way you're going to put the releasable sutures. And mind you, this releasable suture technique is very, very useful and important in titrating post-operatively of left. So once these releasable sutures have been put, then you close the conjunctival suture. Closing of the conjunctival suture also is very important. You need to take anchoring sutures, and so that the blood doesn't get retracted behind. Another variation of making the internal ostium, you can see in these videos. You can use a Kelly sponge, which most of us are well versed with. You can use a Kelly sponge to make an L-shaped opening, or you can use an MVR. You can enter the anterior chamber, cut the trabecular meshwork with the help of an MVR, and then with the help of Vanas, make the internal ostium opening. So this is the way you are going to proceed with the combined disease, that is cataract and glaucoma. And thank you for your kind attention. I hope I finished my presentation on time.
Thank you, Dr. Amit, for such a wonderful presentation. Our next speaker is Dr. Chakitan.
Yes, sir.
Please, Dr. Chakitan, you can share your slides now.
Yes, sir, absolutely.
Dr. Chakitan, he did his DNB in 2005 from Shankar Netralaya, Chennai. He is a fellow of Madras Retina Foundation and did his vitreoretinal fellowship from Shankar Netralaya 2008. In 2008, he completed advanced phaco training from Joseph's Eye Hospital, Tiruchirappalli, that is Tamil Nadu. He did his FRCS from Glasgow 2009. His interest in cataract and refractive surgery grew under the mentors of Prema Pradhanam and Dr. Srinivasan Rao at Shankar Netralaya. He did finish his refractive surgery training in 2016 from Prasad Netralaya, Udupi, under the mentorship of Krishna Prasad Kulludu and Dr. Hari Prasad. He had more than 25 publications, more than 60 scientific papers and posters. He is invited faculty at national and international conferences. He has more than 15 years of experience, performed more than 30,000 cataract surgeries and 4,000 retina surgeries. He is presently director and head of cataract refractive and retina services at Ishwar Eye Center, Rohtak, Haryana. Dr. Chakitan, you can start your presentation, and he will be talking on cataract surgery with additional retinal comorbidities.
Thank you, sir, for your kind introduction. I wish to thank Dr. Veer Vikram Chiller and Dr. Saurabh and the AIOS Scientific Committee for giving me an opportunity to share my views on cataract surgery with comorbid retinal conditions. Phacoemulsification is one of the most successful surgeries performed, 99% success rate. Comorbid retinal conditions can greatly influence success. Immaculate examination, intra, pre, and post-op can save the day for you. And an informed consent and importance of chair time is always there. In eyes with diabetic retinopathy, retina consult is a must for any stage of retinopathy more than mild NPDR. Like this particular patient presented to me very normal looking fundus, not more than mild to moderate retinopathy. I found some suspicious vessels, did an angiography, and was surprised to find a NVE. So this is a proliferative diabetic retinopathy, and our surgical plan changes. We have to manage that first and cataract later. Second, OCT is preferable pre-op, and OCT or OCTA in doubtful staging, as I mentioned. In this particular patient, again for cataract surgeries, a few hemorrhages and few hard exudates away from the fovea. But when you do a OCT, you are surprised that there's a lot of macular edema and even a foveolar neurosensory detachment. So you have to stabilize the macula, the macular edema, and then proceed for cataract surgery. There is a role for concomitant anti-VEGFs in these patients in which macular edema and retinopathy is there, provided it is already stabilized before. And you have to also ascertain whether the cataract is the real cause of vision loss. Close and prolonged follow-up is required as they are more prone to cystoid macular edema. You must stabilize the retinopathy before you proceed. This is an example of a nicely done PRP for an eye, which can now be taken up for cataract surgery. This also provides us a unique opportunity to control their metabolic diseases. This is an example of a cataract of a CRD, combined retinal detachment patient with silicone oil in situ. Silicone oil pushes the capsule anterior and posterior forward. There's a lot of positive pressure, difficult to get the access by cystitome. So I convert to the forceps. However, even with this, it extends. So you have to again make a fresh start and try to make it as much continuous as possible. So we are working at, you have to do a gentle hydro. Sometimes there can be lens touch in such cases. So you do irrigation, but this was my own case. So I knew that, and I prefer 3-piece Iols in such cases whenever there is inadequate capsular support. This is the second video in patient with head nodding, in which I have used capsular hooks. It was a myotic pupil, as diabetic cataracts tend to have it sometimes. So you complete your excess, proceed with your normal phaco. I do stop and chop technique and put in a lens in the eye. Eyes with diabetic macular edema, your aim is to dry the macula as much as possible. Pre-op, this is an example, a patient presented for right eye cataract surgery. I diagnosed macular edema, told her to get macular edema controlled and then get operated. She was in a hurry, went elsewhere, got operated. This vision was 618, post-op vision was 636 with a lens in the eye, and the patient was extremely unhappy. You can see the mound of macular edema. We managed it with multiple anti-VEGFs and finally an Ozurdex to get a dry macula, but the vision deteriorated as the foveal thickness decreased. The vision could not be corrected more than 6-9 parts. So you must have excellent control of diabetes, hypertension, and nephropathy, and pre and post-op OCT is a must in such cases. Another thing which I do in patients is intra-op fundus examination. Suppose patient has an intumescent cataract in one eye and PDR or macular edema in the other eye. I would do, after I finish my phaco and put in the lens, I do a fundus examination to see if there is any PDR or a lot of hard exudates or a lot of macular edema. If that is there, I give on the table anti-VEGF at that time, rather than waiting for post-op period and doing a OCT and then doing, provided I'm sure of the stage of the disease. That helps in controlling the edema and the retinopathy. This is a simple case of cataract surgery in a diabetic patient. So we have gone in with the normal cataract surgery, and towards the end of it, when I finish it, I will give a patient had macular edema, which was previously controlled. But at this point of time, I would give an intravitreal anti-VEGF, Avastin in this particular case. This particular approach stabilizes the disease in a big way and helps prevent complications. Now, in this particular patient, again, a patient with chronic recalcitrant DME, I finished my phaco. There was a small wound leak, so I've sutured it. And now I'm giving a Ozurdex injection, as he has had multiple anti-VEGFs and is a recalcitrant macular edema. So this approach is a really good approach, concomitant anti-VEGF and steroids in patients who have diabetic macular edema and significant retinopathy. So eyes with vascular occlusions, you have to really rule out the etiological systemic condition and treat it. OCT can catch the evasive thief. Sometimes you can have minimal amounts of macular edema, which can really threaten your vision. And also macular ischemia. There are certain patients in which you have to explain GVP. So you should be knowing that macular ischemia is there. Look for troublemakers like neovascularization elsewhere, neovascularization disc, and neovascularization of the angle. In such cases, so gonioscopy is must. Concomitant anti-VEGF can also be given. Patients are more prone to CME. This particular patient had a cataract, but I could see something behind. I could not see the fundus, did a ultrasound and found vitreous hemorrhage. And when we went inside, as you can see, as the vitrectomy progresses, you are able to see a vascular occlusion with a CRA at the macula. So we did endolaser, came out and told the patient that it was extremely guarded visual prognosis for cataract surgery in case he wants to go for it. Eyes with neovascular AMD pose a different kind of challenge. You must suspect it in the first go. This is the patient, right eye had a significant chronic AMD with a lot of exudation, poor visual acuity, finger counting, came for the left eye surgery, and you can see fundus, there is absolutely nothing that you see. So everything is fine. Should we take him up? But I find some suspicious area here, do an angiography and able to detect the CNVM. When you do a OCT, it's confirmed, a double humped PED suggestive of idiopathic polypoidal choroidal vasculopathy. So we first treated the IPCV, the CNVM, and then went ahead with cataract surgery. So you must suspect, screen, stabilize, supplement, support such patients. There are implantable miniaturized telescopes, especially for patients with atrophy at the macula. LVA trials can be given, and controversy of the yellow chromophore. There is no scientific evidence to prove that yellow Iols delay or prevent ARMD. especially in eyes with prior retinal surgery. You can see this patient amount of capsular fibrosis, which is there. This is post retina surgery with oil. Oil removal was done long time back. And you can see I can hardly make a rhexis. It's all piecemeal. And with this rhexis, you cannot continue. So I decide to enlarge it with the scissors. Now we get a slightly decent size. And with heart in our mouth, we proceed slowly with phaco. And it's not that hard. So we are able to manage, slowly bring in the fragments. You have to be careful in these patients. You have to operate at lower settings, low bottle height, moderate settings, careful hydro, and put in the lens. I got away. And I nicked the anterior capsule in the end to provide fibrosis. And especially if a patient has undergone vitrectomy and you find this kind of a cataract developing very early, be extremely careful. It is due to lens touch, due to a cutter or some instrument. These patients can have a complication of nucleus drop intra-op. So you must either be a vitreoretinal surgeon yourself or have a VR backup ready and keep a time slot in the OT. Another thing which you need to look for is oil in the eye. So sometimes in dense cataracts, you'll not be able to see that. So do an ultrasound, especially in eyes which have had retina surgery. That will have an artificial elongation of the globe. And also for biometry, you need to use special constants to do that. Preferably always do these surgeries under local anesthesia. Beware of hypotony post-op in post-vitrectomized eyes, as hypotony can lead to wound leaks. Always suture these wounds. Eyes with epiretinal membrane, VMT and LMH need to be evaluated first. If the main history is metamorphopsia, then you need to do the retina surgery first or need to do a combined surgery. If it is only vision loss and ERM and lamellar holes are small, you can always proceed with cataract surgery first. In this particular patient, cataract and a significant VMT will require a combined surgery. You need to use better and prolonged NSAIDs and do a low bottle height phaco to prevent vitritis. This patient had an ERM worsening, pre-op picture, post-op vision decreased, the macular edema increased, ERM increased, worsened, controlled with NSAIDs, steroids and IOPAR, and the patient was a happy patient in the end. Lamellar macular hole also can progress over time. This is 1 year and this is at 1.5 years. Now the patient has cataract and a significant ERM. At this point of time, we did a combined surgery of ERM removal, lamellar ILM peeling and phaco, and the patient got back very good vision. Such kind of lamellar macular holes and pseudo holes can be left alone and you can proceed with cataract surgeries. Eyes with hereditary retinal conditions, you have to be extremely careful. Surgery should be the last resort. Should be done. RP patients are prone to zonal weakness, and subluxation. Avoid multimodal and multifocal and EDOF lenses. Repeat biometry, as surprise can be there as a patient have fixation issues. This patient was operated 7 years back by me, retinitis pigmentosa, absolutely uncomplicated surgery. And you can see 7 years later, there is an anterior subluxation of both the lenses with the capsular bag. I removed it, sent the pathology material to Dr. Biswas at Shankar Netralaya and found an inflammatory membrane all over. Such kind of a patient with X-linked retinoschisis and edema, defer cataract surgery as much as possible. So to achieve nirvana, use hydrophobic IOLs, avoid silicone IOLs, 3-piece IOLs with PCR, large central rhexis, complete anterior vitrectomy, don't fish in the vitreous cavity for segments, longer NSAID use, and IOL preferences. Thank you so much for a patient hearing.
Thank you. Thank you, Dr. Chakitan, for this wonderful presentation. Our next speaker is Dr. Saurabh Mittal. I'd like to introduce Dr. Saurabh Mittal. Dr. Saurabh Mittal currently holds the position of a consultant and assistant professor at Thind Eye Hospital, Jalandhar. After doing his MBBS from Bangalore Medical College, he did his DNB from Arvind Eye Hospital, Tirunelveli. He did his fellowships in pediatric ophthalmology as well as cornea and refractive surgery fellowship also from Arvind. He has more than 80 years of surgical experience. He has won the St. Atwale Award at AIOS 2008. Dr. Saurabh is a proficient anterior segment surgeon, a versatile squint surgeon, and is into a lot of corneal transplant surgeries. He is very well versed with corneal PK, DASEC, and other corneal surgeries. So Dr. Saurabh will now give us insight how to manage cataract when comorbidities of the cornea have a bad day for us. Dr. Saurabh, please.
Yeah. Dr. Vikram, you have to stop slideshare. Yeah.
Yeah, I've done that.
So good morning, friends. We are into the last of the session, last topics of the session, and my talk will be on cataract surgery through a compromised cornea. So not all cases of cataract surgeries, they bring smile to our faces. There are few which do have these presentations, which involve the corneal surface or the corneal tissues or depth of the cornea, endothelium, stroma, epithelial surfaces, even the extraocular surfaces, the conjunctiva encroaching in cases of pterygiums, dystrophies, corneal scars, uh, already operated for corneal, already operated for keratoplasties. These type of patients, when they come with cataract, they are not easy to handle. They do give us a lot of thought before we plan for the surgery. Once we have thought that we will plan for the surgery, we should first consult the patient that these patients that they might require multiple surgeries to get the best possible visual outcome, and the 100% visual outcome might not be possible because of multiple associations of the disease. So now we take these patients with corneal diseases onto the slit lamp and do a diffuse retroillumination. I basically divide these patients into two different categories, one with where we have a good retroillumination and the one where we don't get a good retroillumination because of the corneal disease. If we get a good retroillumination glow, we plan for the surgery, and in these cases, when we plan for the surgeries, we take it under the microscope. We do have a Lumera 700 and a Leica, which is 822 with a good retinal glow. See, we don't get a good reflex. Once we shift over to the retroillumination mode alone, we do get a very good glow from the background. If you are equipped with the chandeliers, you can use a chandelier endoscopic probe also. That also will give you a very good retrobulbar glow. But it's not possible in all practices. So doing a surgery under only retroillumination will help in proceeding with a good surgical outcome. So we do our axis under this retroillumination. Meanwhile, our diffuse illumination is switched off. The cataract surgery becomes easy. We proceed in a routine procedure. Phacoemulsification is performed and the intraocular lens will be implanted in these cases. Since the glow is good, the surgery is easy. We don't have to. The outcome depends only on the corneal morbidity. So these are the patients where we have a good retinobulbar glow and we can perform the rexes and proceed with the cataract surgery in a very comfortable manner. Now there are cases where there is absence of diffuse retroillumination. Once there is a absence of diffuse retroillumination, it will be difficult for us to visualize the cataract and perform the surgery. Depending upon the level of the corneal involvement, that is the epithelial, subepithelial, stromal, or the endothelial, we will plan our surgery according to the condition. In superficial corneal scars or pterygiums, we will be removing the surface. We will be removing the surface epithelium, or scrape it a little bit. Scrape the whole surface to have a better view of the cataract area. Smoothen the surface with the help of a diamond burr. It's easily available in the market. Once the surface is smooth, you put on a drop of viscoelastic and we can proceed with the cataract surgery the way we did the cataract surgery in the previous scenario where we had a good retro illumination. So we are doing it without a retro illumination on. Once we shift over to a good so we have a fairly good image of the lens, the rexes. So this is how the difference of retroillumination will come in. Doing cataract surgery becomes easier once the retroillumination is switched on. So for pterygiums, we should remove the pterygium first and do a cataract surgery as a routine. If there is a central obesities, along with it, we should do a superficial keratectomy and then proceed with the surgery. When the cataract surgery is because of when the cornea is opaque because of the dense stromal scar, we should be planning for the keratoplasty. The keratoplasty should be done first. We should mark and the circular area. Refining should be depending upon the amount of the corneal scar. Minimal what I suggest is 7.5 or 8. And if the scar is bigger, we can even think of 8.5. After a refination, we have to remove the donor button. We should be injecting a lot of viscoelastic to keep the iris and the lens surface relatively towards the posterior side. After performing the removing the donor button, after removing the button, we put in a lot of viscoelastic, get a good glow of the lens. Try to do a rhexis. If it's not possible, just go in for a can opener type incisions. And once the capsulotomy is completed, just removing the nucleus is not very difficult because the whole tissue tends to come out very easily. Slowly, with the help of Simcoe, we do remove the cortical matter, and then we place the donor button on the top. First, primary sutures are being placed in position. This stabilizes our donor. One after the other, we tend to place another sutures. After completing the 6 sutures, we place in the IOL under the viscoelastics. Prefer doing a multi-piece intraocular lens because we don't know what scenario we will be landing up. The patient is already explained for the results. Once the lens is implanted, we put in all other sutures and form the anterior chamber with a little bit of air and wash all the viscoelastic with the saline. Now, the patient where there is an endothelial compromised endothelial function, it can be after the initial keratoplasties, or it can be because of different dystrophies involving the cornea. We can very well take help of a specular microscope to identify what amount of endothelial dysfunction is there. If the endothelial dysfunction is not great, we can do a routine cataract surgery under the in this case, the endothelial function was not that bad, so we did a routine cataract surgery. In a fashion similar to what we have already explained. Only thing is we use liberal viscoelastic, cohesive viscoelastic, so that the endothelial damage should not be great. The phaco settings should be kept on a lower side. The power of the phaco should be less. So switching over to the retinal illumination always helps in doing surgeries for any type of corneal conditions where the glow is clear. This is a safe and effective technique. Otherwise, we can use a chandeliers light also for doing these surgeries. IOL lens is implanted in the back, and in cases of endothelial function which is severe and cataract surgery has to be done, we plan for a endothelial keratoplasty along with the cataract surgery. Incision is made, large incision is made for performing the DSEC. Since the incision is already big, we plan not for phaco, we will be doing SACS along with the. Even we can do phaco in cases in case we want to make another smaller incision. Since SACS is being planned, we will be making a bigger rhexis that will be around 6 to 7 mm. Cataract is also dense, so the incision, the rhexis depends upon the cataract grade of cataract also. I'm not worried about the endothelium in this particular cases because we are anyhow going to replace the endothelium. This is the last, sorry, this is the last slide.
You continue, Dr. Saurabh, please continue. We have enough time.
Yeah.
Yes, doctor, you can continue.
I'm not getting that video thing. Yeah. So once the rex is completed, we do a hydrodissection, remove the lens with the help of a rectus, wash the anterior chamber of the cortex, and once the cortex is aspirated, we push in the intraocular lens into the bag. Yeah, sorry. We inject, after putting the lens in the bag, we inject the Trifan blue, delineate the endothelial surface with the help of a reverse Himsky hook, and do a DM stripping. After performing the DM stripping, we will take a donor graft which is already prepared. We normally prepare it manually. We'll do a taco and we insert the corneal button inside the anterior chamber. Once the corneal button is inside, we'll just form the anterior chamber, push in a little bit of air, and complete our placement of the donor graft onto the posterior corneal surface. Center the graft, and this completes our combined surgery of dissect with the cataract. Patient generally tends to do very well with these type of surgeries. If we are well versed with all these surgeries, the corneal transplantation, the keratoplasties, the superficial keratectomy, the pterygium excision, we can face this challenge with a smile. And thank you all for being with us and all throughout the session. Over to you, Dr. Vikram.
Yeah, thank you, Dr. Saurabh. Dr. Saurabh, it was really a very fantastic presentation, and I'll really applaud you for putting all your team members in range so that they all finished absolutely bang on time, no overshooting of the time. That was really perfect. All 6, 10 out of 10. That was real right. You handled them. And still, as we wait for the discussions and wait for some questions and answers from the audience, let me try and summarize the take-home messages we have from this presentation. Cataract surgery, as was rightly said in the beginning, it is easy surgery in most of the hands, but when comorbidities like these various conditions are associated with cataract, then it can have a very significant effect on you while performing the surgery. Though there are many comorbidities, but Saurabh has rightly chosen some important one. The first of them, it was high myopia and hypermetropia, that is axial lens, abnormal axial lens. These abnormal axial lens are fraught with their own complications and associated problems. So it is very important to assess the retina in these cases. Then the size of the tunnel is really important. For myopes, a slightly shorter, and for hypermetrop, a slightly longer tunnels. The rexus size. In myopes, there is a very deep AC chamber. For hypermetrop, there's a shallow AC chamber, and placement of the Iols under constantly irrigated anterior chamber is important. So these things are to be taken care of while operating for high myopes or hypermetrops. Then Dr. Love was talking to us about in traumatic cases with traumatic cataracts. Most prevalent, he says, are in the children. That is absolutely right. We see more of traumatic cataracts in the childhood age group. Always seal the primary wound. That is very important take-home message. And look for foreign bodies. You should not miss them because sometimes there can be some retained intraocular foreign bodies, which you have to be very careful.
I am sorry to interrupt you. I need to go to another hall. So if you have any questions or discussion from my topic, can we take that first in 2 or 3 minutes? Am I audible?
Yeah, you are audible, Dr. Porwal.
Yeah, just in 2 or 3 minutes, we finish discussion. If you have any for my topic, then I leave this hall because I have another presentation in another hall.
I think we don't have any such questions as of now. Porwal, you can continue with your other commitments. I know you have a lot of them lined up.
Thank you.
Thank you, Dr. Porwal. Thank you for being there. And I continue with the take-home message for traumatic cataract. It was you have to seal first the primary wound and look for retained foreign bodies. Anterior capsulotomy, vitrectomy has a very significant role. That is quite a learning experience. He has nearly stopped doing vitrectomies with the help of manual forceps. He does it with the help of vitrectomy cutters, and he always prefers a multi-piece IOL. Then we had Dr. Abhilasha speaking on uveitis. An important message: before operating a uveitic eye, wait for 3 months for it to be quiet. And assess always for glaucoma and the retina, especially macula, because these can be quite compromised in case of uveitis. And you should always start the steroids oral, especially when you accept macular edema. That should be done pre-operative itself. And phaco is always eventful in these cases. You will always need pupil expanders like hooks and B-hex ring. That were very nicely demonstrated by her. An important message which she also told: the plane of the main tunnel should be above that of the iris hook tunnel, iris hook. And post-operative, liberal use of steroids is really important to control the inflammation. Dr. Porwal spoke about cataract with glaucoma. He really described very nicely the surgical steps, made the situation very clear when to do a combined surgery or single surgery, and when and how to do a single side or 2-side surgeries. Releasable sutures are in the things which he uses normally uses them, and that they are really important, and they really help you to control the post of IOP if you really master those sutures. Then we had a very fantastic talk by Dr. Cheketan about the retinal comorbidities. With macular edema, he says, always ensure that the macular edema is dried before you operate. Very important. Don't be in a hurry to operate a case of macular edema. Control it nicely before operating it. Otherwise, you will naturally burn your hand. With case of hypermature or intermittent cataract, when you don't have much of an idea about the macular status, always do an indirect ophthalmoscopy on the table. And if you find a macular edema, always better to counsel the patient pre-op about this type of situation coming up and give an anti-VEGF then and there on the table. Then he was talking to us about vascular occlusions with cataract. Always do an angiography to look for macular ischemia, because that can affect your prognosis. And for a patient who had AMD in one eye, always look for subtle signs of AMD in the other eyes. Never forget to do an OCT in such cases. And when doing cataract, always keep your parameters slightly low. So all these messages are really important if you suspect a patient with diabetes or any other occlusions or retinal disorders along with cataract. Then Dr. Saurabh spoke to us about corneal comorbidities. Corneas can have associated scarring or problems right from just the epithelial to the stroma to total involvement. He very nicely demonstrated how a surface problem can be just scraped and smoothened with the help of a diamond burr, and surgery can be done very nicely. The role of retroillumination was very nicely highlighted, and the video shows very clearly how important a retroillumination is, and you just need not tax your eyes while operating if you don't have a retroillumination, which you usually do. So having a retroillumination is really good, especially if I would like to put for the persons or the surgeons who are operating most in the peripheral areas, because there you find a lot of patients with corneal scarrings. And different level of corneal scarrings have different level of management. A full thickness, you should go for a penetrating keratoplasties. Endothelium can be handled with the DSEC surgeries. So these are the few of the take-home messages in the comorbidities associated with cataract. Dr. Saurabh and other distinguished speakers, would you please like to add anything to it?
I would want to discuss with Dr. Abhilasha the role of heparin surface coated IOLs in uveitis. Do you really think it makes a difference, or it is more of hype than reality?
Dr. Abhilasha, are you there?
Ma'am, please unmute yourself.
Sorry, I forgot to unmute myself. Thank you for the question. That's a very important question. The earlier literature said that heparin-coated IOLs do help, but now when we have these acrylic hydrophobic IOLs with square-edge design, I don't think there is a role for heparin-coated IOLs anymore. And they are, we should, at every cost, we should avoid the hydrophilic IOLs. They might be more uveal compatible, but they are not very capsule compatible. And we have capsular phimosis very commonly seen with hydrophilic IOLs. So the preferred IOLs are hydrophobic, acrylic with square edge design with a large capsular axis.
Dr. Chekitan, there is a question for you.
Sure.
We do perform sometimes cataract surgeries in cases where there is silicone oil following the retinal surgery.
Yes.
So sometimes what we get is we get some bubbles of silicone oil. They just keep on moving into the anterior chamber while we are performing the surgery. What do you advise, that we keep on removing those silicone oils, or we just leave a little bit there?
Actually, sir, a small bubble will not create a problem.
No, it keeps on coming actually. We do,
Yes.
my
Yes,
brother is a
because-
retina surgeon, so we do get so many cases, and sometimes there will be large bubbles coming in again and again, and it just hinders the surgery.
True, sir.
So
You can
what do you
actually
say?
remove.
We should remove everything?
No,
If it's coming?
sir, if the oil needs to be left behind in the eye, then of course we cannot, because the more you remove, the more oil will come in the anterior chamber, you know, say if it is at the back. So, but if the eye is oil filled, then there is no point of removing these, because you remove it and more will come. But at the end of the surgery in an oil filled eye, if we suddenly pressurize it, or if we don't suddenly depressurize it, more oil will not come in the anterior chamber. However, if you feel that the silicone oil removal has already been done, and then a few bubbles are coming, then even if you want, you can do a small PPC and remove those bubbles. So that, you know, eliminates a lot of problem for the patient, because patient also keeps complaining, I keep seeing round things here and there. So if that is there, you can always do. Otherwise, in an oil filled eye, there is no option actually, because the more you remove, the more will come. That is the issue.
That is the problem. Once it comes into the anterior chamber, it will stay in the anterior chamber. It will not. It is not going to go back.
Absolutely, absolutely.
So
Sir.
we have to remove whatever comes into the anterior chamber, and
Yes,
it keeps on coming till I think it keeps on coming till the last.
That's true.
So
Sir.
it keeps floating because it has a nature to float. So
Yes, sir. Because the positive pressure, it keeps coming up, sir. Definitely.
Chekitan, I just want to further expand this question. Suppose there's a patient who has oil-filled eye, and we are operating, and the oil just keeps on coming and coming.
Right.
So should we keep on removing it till the maximum we can do, or leave some bubbles here, there in the AC? Because suppose the patient was operated maybe around 2 years back, 6 months back, and that is sufficient time for the oil. I think it warrants removal. But if he just wants a cataract surgeon, sir, why don't you remove it along with that, the surgery? Right. And if it keeps on coming, what should be our plan of action?
If it keeps on coming, then eventually there will be underfill, you know, and if the oil has been left by the retina surgeon, that means the condition is not sufficiently safe to remove the oil, you know, because otherwise it would be removed within 3 to 6 months. So if it is not removed, then there are chances that if we remove the oil completely, there are chances that the retina will redetach. That means something is wrong in the retina. That's why so I think from the beginning only, if you see some bubbles before you start operating, you should use a you know, Helon or some such a this thing which pushes the bag and seals the zonules, you know. So at that, so operate under Helon with the soft shell technique, so that you protect the endothelium also, and have minimum manipulations in the anterior, no fluctuations. So even if suddenly if you have more aspiration, or if you have more vacuum, more oil will come in. So if you have very, very stable parameters, operate on lower bottle height, you know, and you have Helon and something, and that it's very unlikely that more oil will come in, you know. But if it keeps on coming, then you have to, in the end, you have to remove. But if there are very small bubbles, maybe 1 or 2 mm in size, you can leave it at the end. This is not a problem. It is not that much endotheliotoxic. We have oil in the eyes for years and years and years and small bubbles and nothing happens. But it shouldn't be very large. And preferably, if you have such a situation, do a PI in the end, because that can block the pupil and lead to trouble.
Okay,
It should be inferior.
Sorry to interrupt, sir. Sorry to interrupt, sir. The time is up and we have to move on to the next session.
Yeah, thank you, Raj.
Thank you, sir.
We thank all the delegates who have attended this particular session, and hopefully we will be coming up with the similar sessions in future also. Thanks a lot to all the presenters and the delegates.
Thank you so much, sir. I thank all the speakers for the wonderful session and keeping it on time. Thank you so much, sir. By this, we come to the end of the session. Thank you. Stay safe.
Thank you so much. Thank you, everybody. Thank you so much.